Good morning, everyone. Thank you for joining us today for our virtual spine conference here at Mayo Clinic. I'm Arjun, Sebastian. I'm an orthopedic spine surgeon here at Mayo Clinic. We're going to be joined soon by one of my partners, Dr. Brad Currier. And we have two of our excellent spine fellows here to assist us with the Journal Club, Dr. Jad Boumansef and Dr. Sandra Hobson. So, we'll encourage everyone to please feel free to use the chat functions, and we'll leave some time after each article, there are 4 today, to discuss or ask any questions. The topic today is spinal metastasis, and so without any other delay, I'll let Dr. Boumansef get started with our first article, Assessing the Utility and Clinical Prediction Score regarding 30-day morbidity and mortality following metastatic spinal surgery using the New England Spinal Metastasis Score. Jad.
Thank you, Dr. Sebastian. Can everybody hear me? All right. Thank you, everyone, for joining. Survival prognosis is one of the most important considerations for patients with metastatic tumors in the spine. And I'll be covering 2 of the scores that try to make sense of the factors that predict prognosis in a matter of saying. And the first one is this paper that tries to look at the New England Spinal Metastasis Score that was published in 2015 as a tool to predict 30-day morbidity and mortality following surgery for metastasis in the spine. The actual original New England Spinal Metastasis Score evaluated a 1-year mortality, and we'll cover that in a bit more detail throughout the paper. It's the same group that was participated with the original project. So this project actually looked at the NESQIP database, and they got it's about 776 patients. The original paper had looked at 300 patients and followed them for a year to consider the 1-year mortality rate, and they came up with the score that included the 3 points that were significant and correlated with 1-year mortality. And those were the Bauer scoring system and the serum albumin and the ambulatory status. We'll cover those in a bit more detail just before we talk about this paper. The modified Bauer scoring system highlights 3 points as positive predictors for survival, one being no visceral metastasis, the other one primary tumor not being a lung cancer, and then the third is breast renal lymphoma or myeloma, and 1 point to single skeletal mets. This score, if it's low, it will give you 0 points, and low being less than 2. And then if a modified Bauer score is more than 3, they would allocate 2 points. The ambulatory status is 1 or 0, it's just binary. And the serum albumin as a cutoff was also 3.5 binary. And then you get a score over 3. And the original paper found almost a 75% correlation with this score, predicting survival up to 1 year post-op. So this current paper looked at the same patient population. However, they wanted to apply it to the 30-day mortality rate as well as the major systemic complications and what they called failure to rescue, which is dying from a major complication, and reoperation rate as well as readmission rate. The database they looked at, unfortunately, only follows patients for 30 days, and it doesn't really specify the primary type of the tumor, but they were able to calculate the spinal metastasis score by calculating the Bauer score based on whether the ICD-9 code said that they had diffuse Mets or not. However, very few of those specified what the actual tumor was. And they also were able to find the albumin and the ambulatory status. And they calculated these scores for the number of patients on the NESQIP database. And then they found that the mortality rate the complication rate and the major systemic complications were significantly lower as you go up in the score to a score of 3. And per their calculations, it's about a 10% decrease in mortality rate and a 10% decrease in complication rate as you go from a 0 to a 1, from a 1, from a 2, and then from a 2 to a 3. They also had most patients in the 2 category, and then 1/3 of the patients in 1 and 3, and few patients in 0. Now, it's important to mention here that this only looks at surgical patients, and the patients that were treated non-operatively would not be covered in this database. This is the modified Bauer score that initially described the median survival for the different scores as less than 6 months, about 1.5 years, and a bit more than 2 years, with a score of 3 to 4. So after that, they did a analysis of the area under the curve to look at the significance of this score as a predictor of 30-day mortality as well as major complications. And basically, the line in the middle represents no result, and 1 being the highest. This scored about 70% validity as a predictor tool, and they got the same result when they did simulated more patients, and they call it a bootstrap analysis, in which they ran simulations to validate their statistics, and they found that it stood the test. So I think all in all, this paper validates the New England spinal metastasis score as a potential tool to, look at the prognosis of patients even within the 30-day, and also as the major complications, which they looked at, included the pneumonia, the UTIs, the DVTs. So they looked at most things, and it does apply when you're looking at the mortality about a year, but the limitations are significant in the way that they don't look at what the primary tumor is. The Bauer score was calculated by rounding up and down because they didn't always have all the data, and also the fact that the NESCOT database doesn't look at conservative treatment. So there's a lot of patients that we're not looking at, and that would affect significantly, I would think, the validity of it as a prognostic tool.
Thank you, Jad. That was a nice summary of the article. I guess I'd be curious from some of our panelists if Dr. Courier's on, or any of the other panelists want to weigh in on what scoring systems that they find helpful, or what factors they utilize to sort of determine risk, and at what point do they get concerned or maybe counsel patients about conservative treatment.
This is Izzy Lieberman. I must admit, over the years, I've gotten less and less enthralled or excited about using a lot of these systems. Patients today just keep surprising us, and the oncologists are doing so much better with it. I think when you just look at a patient, they're cachectic, they're not doing well. Those are ones that you can tell right away, and I suspect the way that Jad had presented it, those patients aren't even included in this paper. So you're missing a whole group that you're not going to get to the OR with that. So I think a lot of these scoring systems really are more academic than practical for us right now.
This is Brad Courier. Thanks, Izzy. Hi. One of the reasons that we included this particular paper is that I just recertified for my boards, and this is on the WLA pathway, and this is one of the papers that was chosen by the board for continued CME. And, I think you're absolutely right. And the authors of this paper point out that this shouldn't be used as a hard stop for who to or who not to operate on, but it opens up the door. And I think especially for new surgeons, it's useful to look at these scoring systems to try to get a sense for survival and, as this paper does, also morbidity. And so I think it's a useful tool for counseling. I don't think it should be used as a hard stop one way or the other. But I think it is useful because, as I'm sure all the experienced spine surgeons on the line have experienced operating on someone to try to improve their quality of life, and then just having the heartache of watching their final days consumed by complications and a long hospitalization instead of just dying peacefully at home with their family. And so trying to identify those patients who are very likely to have lots of complications, especially for younger surgeons, I think these scoring systems can be of value.
Thank you, Dr. Currier. I think
Steve Bervin here from UCSF, and I agree with you. I think the value of scoring systems, starting with Tomita and then Takahashi, and then moving on to this is really quite useful. The derivation of this scoring system really doesn't involve the granularity that I would expect. I think that Izzy made some really important points regarding some other considerations, and I think now this New England system was really derived using a multivariate type of analysis, and I think that using some more modern techniques of machine learning and artificial intelligence, we can get a lot more granularity, both with large data sets as well as with oncology study groups, and something that I think is also important for informed choice, both for patients as well as for oncologists and surgeons, to try and have as much information as possible to empower informed choice. And I think there's a lot more that needs to be done in this area. I think that right now the NEMS system really isn't as granular as I would expect it to be. And it misses a lot of variables and comorbidities.
No question.
No, I think that's an excellent point. I think we, Dr. Currier and I were just on a meeting trying to look at, ways that we can sort of improve our algorithms for treating metastatic disease. And certainly it's probably going to involve some sort of multidisciplinary approach, working with our oncology and radiation oncology partners to sort of figure out, how to optimize the care of these patients. And certainly there's a long way to go. In terms of other factors, I think Chad brought these up with this particular paper, but I think it's important to keep in mind that specifically for this one, the NISQIP database only looks at patients who have had surgery. So, they didn't look at a combination of sort of operative and non-operative cohorts. And the other important thing that he also brought up to keep in mind when we're looking at this paper is that, for most of these patients, they weren't able to identify the histology. And I know some of the other papers we're going to look at today specifically look at survival related to the tumor type, which I think is really important. Dr. Currier, are there any specific you mentioned, and I think some of the senior surgeons here have mentioned that they have sort of a gestalt or a sense of the things that they look at. What are some important factors that you look at in terms of labs, patient functional status, to sort of help you make that decision in your own practice?
Sure. So, the albumin, like in this paper, LDH, there's a number of different labs that give you a sense for their systemic situation. But I think the most important piece of this is just understanding that this is a real team approach. And so all of these tools and the Takahashi that we'll discuss in just a moment are incredibly, as Sig pointed out, very blunt tools. And they are losing their edge over time, too. And so they're just starting points. They're just starting points for evaluating some of the key factors. But there are so many other things that are important in terms of the genetic profile of the patient, the histologic subtype, and as we improve our accuracy as we have more advancements in medical and surgical care, these tools are going to become less and less accurate all the time. And so it's the big picture, and it's the team approach, making sure that you understand all the advancements that are occurring that may change your tumor type. And probably we need to be looking at each of these tumors separately. We should at least have a modifier for each tumor type. And as Sig said, machine learning is just perfect for this.
Great. It looks like we have a couple of comments in the chat box right now. One of the questions from Dr. Bindajim is, stereotactic radiation is not included in the scoring system. Does anyone have any takes on stereotactic? It looks like, I think that's a great point. Most of these sort of are comparing tradition, at least most of the classic papers compare sort of traditional radiotherapy to conventional surgery, and yet we know that there's been advances from surgical technique standpoints, as well as advances in radiotherapy. We have a big proton beam center here at Mayo, what are your thoughts, Dr. Currier, to the rest of our panelists? Do you think at some point we may be doing less and less surgery as our radiation oncology treatments improve?
I think there's no question about it. If you think back just before Bilski's paper on separation surgery, the magnitude of surgery we were doing at that time, and then we realized that with stereotactic surgery, we didn't need a whole lot of separation in order to achieve the same or better goals. And so as radiation improves, as chemotherapy improves, our surgical techniques are going to change, but that doesn't mean we're necessarily going to be doing less surgery. We're just probably going to be doing it differently, more minimally invasive surgery. There'll be more role for percutaneous procedures.
Excellent. Well, to keep us on schedule here, and a good segue to our next article, Dr. Boumansef will be reviewing the revised scoring system for preoperative evaluation of metastatic tumor prognosis, the paper by Takahashi that's been already referenced a few times. So Dr. Boumansef, I'll have him take it away.
Thank you, Dr. Sebastian. So this is a landmark paper that is unique because it tries to answer two questions, one relating to the prognosis, and second, it tries to guide treatment with the scoring system. The original scoring system was published by Takahashi in the 90s based on a series of patients that were treated, and eventually he revised the score to give double the weight on the primary side of the cancer. So the whole score initially was on a set of 0 to 2, and then the revised score just gives the weight of 5 points on the primary side of cancer, which we'll discuss how it gets allocated into the score itself. The point of his revised study was to follow patients prospectively based on the score that was initially published in the 90s and then revised, and then he looked at the entire cohort of the patients retrospectively and calculated the validity of the score as a predictor of mortality. And also the treatment decisions were guided by these scores as well. His study included 164 patients who were treated operatively, and those fell into two categories: palliative surgery and excisional surgery. And the distinction was made based on the score that was obtained. So if the life expectancy, which was predicted by the score being less than 8, was less than 6 months, then patients were treated conservatively. If the patients were in the second group of life expectancy, which is greater than 6 months, but then maybe less than a year, they would do mostly palliative surgery, which was this decompression without en bloc removal of the tumor, unless the patient had a specific case of a solitary met with the ability to do excisional surgery, then they would do it in specific cases. And then the en bloc resections were done with patients who scored the highest, who basically had a life expectancy of more than a year. And whenever they were able to, they tried to remove those tumors en bloc and give the patients the best chance of cure. You can see here some of the cases as the anterior curettage and stabilization cervical were part of both, because sometimes it was performed as a decompression and debulking surgery or separation surgery. Sometimes it was to remove the whole tumor. And they also had 82 patients in the conservative treatment arm. And those, some of them got radiation, chemotherapy, hormonal therapy, or just palliative care. They did not include vertebroplasty or kyphoplasty. And initially, when they did calculated the original score, their correlation with the mortality rate was about 60%. And they wanted to recreate this by weighing more on the primary site of the cancer and by relying on their original study and the average mortality rates for the different tumors that were seen in that study. So they would assign the lowest points for the patients who had less than 6 months to live with mostly lung cancer, osteosarc, and stomach, bladder, esophagus, and pancreatic cancer. And then the patients who had the longest survival expectancy were the thyroid, breast, and prostate. And rectum, they gave a category on its own because they found that a longer survival than the literature, but they wanted to be somewhere in between. Kidney and uterus survive almost a year, and then these also were based on results, and they would assign one if you could survive more than 6 months. So by weighing the primary tumor more and the other variables being the performance status that is mirrored in two variables. One, the Karnofsky performance status scale, which gives 0 points if you're unable to care for yourself. Midway, you're able to live at home, but you're not able to work. And then 3 points if you're able to do normal activity and work, even with some effort or signs of disease. And then the palsy here, they associated with the Frankel classification, which basically is either complete or sensory only, which they get 0 points. And then if you're perfect, you get 2 points. And anywhere in between, you get 1 point. And they also weigh the number of metastases in the body, both as extraspinal foci and in the vertebral body, and a metastasis to the major internal organs, which is something we see highlighted in the Bauer classification as well. So the treatment algorithm was, as we said, 0 to 8. You can you get treated conservatively, whether that means radiotherapy, chemotherapy, or palliative care, with a predicted prognosis of less than 6 months survival. And then somewhere in between, you either get palliative surgery if it's a single lesion with no mets, or excisional surgery, and 12 to 15 if you have a prognosis to live more than 1 year, you get excisional surgery. And when they looked at the single points as they related to the survival periods, they found that they did correlate with the higher points surviving in the ranges that were predicted by their classification system. And ultimately, looking at the total scores as well as the survival periods, they had a higher than 80% correlation with their scoring system, and that applied both to the entire group, and then when they looked at the subgroups, and also this was reflected in the results when they looked at them prospectively and retrospectively as well. And this is when they plotted the Kaplan-Meier curves for the survival of each group, and they found significant differences in the groups as segregated by the revised scoring system into less than 8, 9 to 11, and 12 to 15. One important thing to note is that a lot of papers, because of the overlap here, which this doesn't specify an upper range, it basically says you can survive more than 6 months, and this is more than 1 year. So this overlap here sometimes is missed in the papers, and they categorize it as less than 6 months, 6 months to a year, and then greater than 1 year, and that's false. And this is just looking at the distribution of the total score and the survival period. Again, they found the correlation both in the prospective and the retrospective data. Sorry. So that's the end of this paper. I think this goes further in trying to guide treatment as well as establish prognosis. But the limitation is what Dr. Courier highlighted earlier, in that this paper is rooted in prognostic factors of the primary tumor that were a snapshot of the first study in the 90s, and even in the revision in 2005. This doesn't reflect any changes in treatment or survivorship in any of the on the primary tumors, and it doesn't reflect any of the surgical advances that we have or the advances that are in radiotherapy. So a lot of papers have actually argued that it hurts certain kinds of tumors because it weighs them less heavily. For example, it's been said that it doesn't reflect well on kidney cancer as well as it reflects on lung cancer. And also lung cancer has started changing in the last few years. So if it does, then it won't reflect that either. So I think it highlights the importance of looking at the patient as a whole and what to look at in terms of ambulatory status, whether it's albumin or LDH, but also having a discussion with the people who are specialized and who can actually say, with this kind of tumor, with this kind of patient, if there's anything more we can do, or take an individualized approach rather than try to bog it down on a 1 or 2 scoring systems. Thank you.
Thank you, Jad. I think you highlighted all the key points. This is obviously a classic article, and one that everybody should be familiar with. I think that one of the more helpful parts of this article is they broke down tumor subtype, which our last more recent article didn't do, and so I think that's kind of an interesting takeaway. But you're exactly right in that it doesn't reflect some of the changes to treatment, especially from the non-surgical side that have come about. I guess to our panelists and Dr. Courier, do you think there's any role for excisional surgery still, or more radical resections for metastatic disease? In today's environment with all the advances we have in chemo and radiation therapy?
We did do that occasionally for renal cell tumors that were isolated, and it's very uncommon that we would do an excisional marginal or wide excision for a metastatic lesion now, just as you say, with the advancements in radiation therapy especially. We just wanted to include this article because it is a classic, but a lot of people are still using this, and even Takahashi has recognized that its accuracy has deteriorated over time, and that there's a lot of other factors that need to be considered in this. And he has a 2018 article looking more specifically at lung cancer and trying to subtype things and getting better accuracy there. But again, it just comes down to this. There's such a wealth of knowledge that we really need that team approach, and don't rely on any of these kind of scoring systems. Just a good start.
Thank you, Dr. Courier. Probably to keep us on time, I know there are some questions probably, but to keep us on time, we'll probably jump into our next article, and then hopefully we'll have some time to discuss following this. Dr. Hobson is going to discuss a novel classification for spinal instability in neoplastic disease.
All right. Good morning, everyone. I'm Sandra Hobson, one of the fellows at Mayo, and will be joining the faculty at Emory University this fall. Thanks for having me. So the third paper we're going to talk about is about the SINS criteria. So this is a paper that was published about 10 years ago in 2010 in Spine, and it's essentially an expert consensus about spinal instability in neoplastic disease developed by the Spine Oncology Study Group. So the background, the setting that this paper was done in is that spinal instability in patients with metastatic disease was, and to some extent is still relatively poorly defined. And then despite that, spinal instability remains an important part of surgical decision-making for these patients. The other articles we've talked about have focused on survival, which is very important. There's also neurologic symptoms, which are obviously important. And this article wanted to focus on spinal instability as one component. And there was a lack of guideline for decision-making, especially for non-surgeons, because as surgeons, we're kind of the last stop for these patients. And the Spine Oncology Study Group wanted to put together some criteria so that for non-surgeons, such as oncologists who are routinely evaluating these patients, they would have a better sense of which patients could be best served for a referral to a surgeon from an instability standpoint. So the clinical question this article was trying to answer is, if you're a non-surgeon, such as an oncologist, when should you refer a patient with metastatic spine disease for surgical evaluation? And it's really from a setting of an instability standpoint. And even though, 10 years later, as surgeons, we often look at this article and reference it in the setting of, should I operate on this patient for instability? Just keep in mind that that was not the original point of the article, although certainly you can use this SINS criteria to walk yourself through your own clinical decision for a patient. So the methods of this article, they conducted a systematic review first, then they used a formalized method called the modified Delphi method to form a consensus statement from 30 spine oncology experts called the Spine Oncology Study Group. And we can go into the details about modified Delphi method if you want, but for now I'm going to skip over that. So in very brief, they identified potential important criteria that they could consider would make a spinal lesion unstable. And ultimately, from about 40 factors, they narrowed it down to the 6 most important factors as well as their relative weights. And these 6 factors that they looked at, or felt the expert consensus opinion felt that were most important, would be the lesion of the location within the spine, mechanical pain, the bone lesion quality, and this is in reference to whether it's a blastic lesion versus a lytic lesion versus mixed, the overall global alignment of the spine, or rather the regional alignment at the level of disease, also vertebral body collapse, and finally posterior lateral involvement of the spinal elements. And it's just important to note that of these 6 factors, 1 is clinical, so mechanical pain, but the remaining 5 are more radiographic factors. So if you look at the actual summary of the SINS criteria that they came up with, the first one is location, with junctional being the most unstable and rigid being the most stable. And so the higher the score, the more unstable or the more likely the patient is to have mechanical instability. So the second we talked about is the 1 clinical factor that's part of this score. And so this is pain relief with recumbency, basically mechanical pain with motion. And if the answer is yes, you have more points. And if it's a pain-free lesion, you have 0 points. The third, which we mentioned already, is whether it's a lytic, mixed, or blastic lesion, with more instability being assigned to lytic lesions and less instability for blastic lesions. Then fourth is the radiographic spinal alignment through the region. And so if the patient has gross subluxation or translation, that was thought to denote the most evidence of instability, kyphosis or scoliosis, a moderate amount, and normal alignment with no contribution to instability. The third was the amount of vertebral body collapse, and they look at the percent, whether it's greater than 50 or less than 50% collapse, either no collapse with significant tumor involvement. So it's almost kind of a acknowledgement of potential impending collapse with the no collapse with greater than 50% of the body involved. And then finally, the sixth criteria is posterolateral involvement of the spinal elements. So this is acknowledging that the posterior elements are very important, and instability is very different in neoplastic disease compared to trauma, but this is certainly similar to traumatic disease where you're trying to decide, do the posterolateral elements, if they're involved, we would tend to think of that as a more unstable lesion. And with all this, they use this to place patients in 3 categories. So if you have a score from 0 to 6, the experts felt that denoted stability. The score of 13 to 18, they felt denoted instability. And then a score of 7 to 12 was indeterminate. And their recommendation is that if you're a non-operative provider and you saw a patient with a lesion and their score was 7 or higher, they recommended a surgical evaluation based on instability. And the article itself has 3 sample cases, but I'll run through one sample case fairly quickly. So this was an elderly gentleman who was ultimately diagnosed with metastatic lung cancer who had greater occipital neuralgia unilaterally, as well as severe upper cervical pain that was relieved with rest. So just as this is a sample case walking through his SIN score, so if you're looking at his location, it's in occiput to C2. It's a C2 lesion here, so you got 3 points for that. Now, pain relief with recumbency, yes, so the patient gets 3 points for that. The type of lesion, lytic, mixed, or blastic. If you look here on imaging, this is a lytic lesion, so he gets 2 points for that. Then the radiographic spinal alignment, in his case, if you note, I don't know if you can see my mouse here, but there is some settling with the C1 lateral mass kind of subsiding into C2. So the authors categorized that as subluxation translation present, giving him a 4 for that. Vertebral body collapse. The authors of this study talked about how they described this as no collapse with greater than 50% of the body involved. And then finally, they categorized this as a 1 for unilateral for posterolateral involvement. And this gives him a total score of about 14. And I think the one thing that you can take away even from this sample case is that this is a very helpful score, but some people might assign slightly different scoring systems to even the same patient. So there was not necessarily a full description of inter and interrelated reliability in this particular study for this scoring system. So discussion points for this study, I think, neoplastic instability is fundamentally different than traumatic instability, which we briefly mentioned. And so this study was trying to better define neoplastic instability. It considers clinical and radiographic factors with a heavy reliance on radiographic factors. And as we were talking about with the prior article, surgical decision requires consideration of a vast number of factors, and instability is really only one factor. And this article is really only set up to address instability. This article was designed to be applied at a single site of disease as opposed to multiple contiguous or non-contiguous lesions. And also prior surgical intervention and treatment stage and tumor type were not considered. I think the key points for the average reader would be this is just one tool for assessing neoplastic spinal instability. It was formed by a consensus statement of experts in spinal oncology. And while we frequently do use it as surgeons, it was originally designed for non-surgeon use. And I'd like to open it for discussion.
Thank you, Sandy. That was an excellent review. I'm excited to see we actually have one of the co-authors on the paper and one of the members of the group here, Dr. Bervin. So I'd be really curious to hear his thoughts on how he takes this information and applies it to his own practice.
Yeah, so thanks for the opportunity. I think this is a paper that I hope others have found somewhat useful. We recognize there's a lot of variation in the management of tumors. And certainly there's a lot of different parties involved in managing both primary as well as metastatic tumors involved in the spine. And I think oftentimes there's not enough interdisciplinary collaboration. I think that was brought up by a couple of speakers earlier, including Brad, is the importance of having an interdisciplinary panel and really understanding everything from prognosis to stability of the spine, and really where stabilization of the spine is an appropriate intervention. And I think sometimes we see an over-enthusiasm for massive stabilizations, resulting in what Brad said is what's one of the worst outcomes is people who end up dying while recovering from complications of major surgery. And at the same time, the corollary to that is what one of my mentors, Henry Mencken, used to say is never underestimate the survival of a patient with a tumor. And certainly some of the tragedies we see in patients who outlive the expected survival from an inadequate surgery. So to that end, the purpose of this paper was really to try and have some interface between the surgeons and the non-surgeons with regard to when is stabilization of the spine using some technique. It could range from a vertebral augmentation to a major reconstruction. Is when is stabilization appropriate versus when is some of the ever-growing options with regard to ancillary treatments appropriate? When is the spine stable enough to undergo things like radiation and other ancillary therapies? I'll say briefly that the derivation of this was interesting. This was a oncology study group, a spine oncology study group, and I was fortunate to be part of this. And on the day that this came up, the group was predominantly a group of neurosurgeons, and I had brought up Morell's criteria as being something that's relatively useful in assessing stability of the appendicular skeleton. So what this really was an effort by a panel to put together a spine version of Morell's criteria. And I think overall we can maybe be a bit critical of any of the individual elements, but I think it had to do with face validity of what do we look at when we look at an X-ray to try and get an idea of whether or not somebody's an appropriate candidate for stabilization. So sort of the spine version of Morell's criteria. But I'd be interested in how others maybe have found this useful or useless.
So Arjun, this is Jens. Thank you, Mayo, for a great subject matter, and congratulations to the fellows. I'm going to harp a little bit on my AO colleague, Dr. Bervin, with the first comment. When we do a binary classification, so basically we want to differentiate stable versus unstable, one of the greatest problems is if we have an intermediate group. And so this intermediate group, as you see point-wise, is very large. Now, we use the sin score routinely. It's in our EPIC kind of a smart phrase catalog. But it is very common that we basically land bingo in that very large intermediate group. So a plea going forward is when we do these kind of scoring systems and has a binary intent, keeping that intermediate group as small as possible would be maybe a learning point going forward. Halt here maybe, and maybe Sig can defend himself there.
Thanks for your criticism on that. And Jens, I agree. I think sometimes binary isn't right. Sometimes binary isn't the goal. And really, the intermediate goal, the intermediate criteria, the reason that's so large is to encourage interdisciplinary decision making. I think the vast majority of these cases really ought not be made as a yes, no, but as a maybe. This is something that there's a lot more that goes into this. There's a lot of clinical considerations. I think the biggest thing that goes into this is really the patient values, the patient's expectations. And so in many ways, I think binary is problematic. I think binary would undermine any validation of this effort because there'd be so many examples that just don't fit. So to that end, I think to some extent, the intermediate zone invites more discussion of other factors.
So let me take you up on that then. So discussion, we heard a lot, and Brad pointed out, Arjun pointed out, of teamwork. And in oncologic care, there can be no mistake that this is probably one of the essential things that we have arrived at. And the chats reflected that there's something new happening in any and all disciplines all the time. So this is my question. When we present spine cases at our tumor board, which is multi-specialty, there are long faces with complete absence of any recognition of any of these wonderful scores that we have. And what means so much to us, and what we're talking and teaching all the time, is almost unheard of in the oncologic world, at least in our neck of the woods. So I don't know how that is in other centers. In LA, we have great members, obviously, of Texas here also. But for us, our oncologists, they live in a different world, and this is all just kind of something.
You know, again, the idea of these long faces backed by remarkable ignorance that's exactly what we need, not treating patients individually. And I think, you know, when this was intended, again, for oncologists who are thinking, hey, is this something I ought to irradiate? Is this something we ought to, refer to a surgeon? And really, the idea was a good number of these, including all the intermediate cases, ought to be discussed in the interdisciplinary panel. I think there's too little interdisciplinary work that's done, and we end up seeing the consequences of either inadequate stabilization, you know, patients who are radiated with neurologic deficits and instability, or the opposite, patients who undergo incredibly involved surgery that are fraught with complications for something that really was a relatively stable lesion. So really, I think a big part of this is making sure cases are discussed, again, in an interdisciplinary fashion, getting surgeons and the oncologists in the same room. And I think any center that's really doing a significant volume of tumor work, and I'm sure I'd be interested in what you do at the Mayo with regard to these cases, but any center that's doing a significant volume of tumor work needs to have all the parties in the room.
Absolutely. Great points, both of you. And this is a real classic paper that's still extremely useful. In fact, we just discussed it this morning at our research meeting when we were talking about metastatic spine disease. And I was very happy that one of the physiatrists was very familiar with this work and uses it. And so it just takes rubbing shoulders with your colleagues and educating them, just as allowing them to educate us.
Great. Thank you, everybody, for your comments. That was a great discussion. I think the last paper we're going to cover here, Dr. Hobson's going to do that for us, is, obviously a very classic paper as well, looking at direct decompressive surgical resection for spinal cord compression caused by metastatic cancer. This was the famous Patchell study out of Lancet, and I'll let Dr. Hobson take it away.
All right. Thanks, Dr. Sebastian. So he gave a great introduction. This is a classic article published about 15 years ago now in Lancet. And the key author behind the study was Dr. Patchell of the University of Kentucky. And so the background behind this study about 15 years ago, at the time, my understanding is that surgical treatment for metastatic epidural spinal cord compression was not necessarily widespread. In the past, some patients had undergone laminectomy alone, and some small studies didn't demonstrate any benefit of surgery. And at that time, surgery was generally laminectomy alone compared to radiation and corticosteroids. And this is a very general statement talking about radiosensitive tumors in general. And so no studies compared direct decompression, especially addressing anterior compression, compared to radiation and corticosteroids. So the author's clinical question was, how does direct decompressive surgery for metastatic epidural spinal cord compression compare to the standard treatment of the time, which was defined as radiation and corticosteroids without surgery? And the primary endpoint of this study was the ability to walk, and they also looked at the length of time a patient was able to walk. And the secondary endpoints that they investigated were urinary continence, muscle strength, functional status, need for corticosteroids and opioids, and survival time. So the method of this study included a randomized, multi-center, non-blinded clinical trial. Inclusion criteria consisted of patients who were adults 18 years or older. They had a tissue-proven cancer diagnosis and MRI evidence of metastatic epidural spinal cord compression, and at least one neurologic sign or symptom, and this did include pain. You were allowed to be included if you were paraplegic for less than 48 hours. They wanted an expected survival of at least 3 months, and that discussion, again, could go on for a long time, but we'll continue on here. And then a single site of compressive disease. You were able to be enrolled if you had multiple sites of disease, but not multiple compressive sites of disease. And exclusion criteria were very radiosensitive tumors, such as multiple myeloma, lymphoma, and leukemia. Also, tumors that involved only root level or cauda level compression. Also, patients with prior radiation or brain metastases were excluded. It's also important to note that you were able to be randomized if you had what they defined as an unstable lesion. So the randomization was done within strata by permutated blocks, and the stratification was based on 4 criteria. So the treating institution, tumor type, ambulatory status, and relative stability. And this was done before the SENS criteria, so they actually used a different criteria looking to define relative stability. All patients received corticosteroids. The patients randomized to the radiation group were given a standard dose of radiation in 10 fractions, and this started within 24 hours of entry into the study. The other set of patients, so there are 2 randomization groups, the first being radiation, the second being surgery. If you were randomized to surgery, you received a surgical intervention within 24 hours. Now, they didn't dictate the type of surgery that had to be done. Just the goal of the surgery was circumferential decompression. And then after this, radiation was also administered within 14 days postoperatively. So this is a flow chart for the enrollment of the study. About 123 patients were assessed, 22 were excluded, 101 were randomized, with 50 to the surgery group and 51 to the radiation group. And overall, although there were 5 patients who were non-compliant, they did end up analyzing all 101. It's important to note that they were actually targeting an enrollment of 200 patients, but they did a interim analysis of the first 100 patients, which revealed such clinically significant results that they decided to stop the study. And all analyses were performed with an intention to treat and not crossover. It's important to note that although all the analyses were done as intention to treat, about 10 patients, which is 20% in the radiation group, developed a neurologic decline and ultimately crossed over to surgical intervention. However, those patients in the statistical analysis were still treated as part of the radiation group. So this is a very busy table, but basically it summarizes some of the demographic data of the 2 cohorts, the radiation group and the surgery group. And I think some key takeaways are that the age is about the same. The distribution of tumor type, although it included many types of tumor, lung, breast, melanoma, they were similar in the 2 groups. And then the locations of the tumor and other things were relatively similar, although they did not publish p-values or statistical significance with these. So when they looked at their primary outcome, which was ambulatory status, the post-ambulatory rate in the surgery group was 84%, compared to 57% in the radiation group, which was highly statistically significant. And then patients retained the ability to walk in the surgery group for much longer, 122 days, compared to the radiation group, which was 13 days. And they have this Kaplan-Meier estimates of the length of time all study patients remained ambulatory after treatment. Then this is looking at their secondary outcomes, which, if you remember, involved urinary continence, the ASIA score, as well as the Frankel score and survival time. And it's just interesting to note that there was a statistically significant increased survival with the surgery group. Continue on here. I think some key discussion points for this article, it's a classic, and this is a direct quote from their discussion. They say that surgery allows most patients to remain ambulatory for the remainder of their lives, whereas patients treated with radiation alone spend a substantial portion of their remaining time paraplegic. I think other discussion points are surgical intervention provides a faster decompression than radiation, and they do spend some time discussing the multifactorial factors that go into someone ultimately becoming paraplegic from tumor, but the general thought is that the ultimate final event is often a vascular event that is irreversible. So surgical intervention can potentially avoid a permanent cord infarction. 30-day morbidity, interestingly, was worse in the radiation group, despite concerns for morbidity in the surgical group with postoperative complications. And I think one other thing to consider in our discussion after this is considerations about randomizing patients who, according to their stability criteria, were considered unstable. They were able to be randomized to the non-operative, radiation-only cohort, and whether that's, truly someone who's eligible for non-operative treatment, I think could be subject to criticism. And I think this is a classic study, but I think less so than the SENS article, but similar to the first two, it's certainly now 15 years later, subject to criticism, and the difference in survival with new techniques in radiation, as well as new other adjunct techniques such as chemotherapy. I think the key point that I had from this article is that surgical intervention for metastatic epidural spinal cord compression in certain patients can provide increased likelihood of maintenance of ambulatory status, as well as maintaining this ambulatory status for longer, potentially increase survival, and without the increase in morbidity due to postoperative complications. Love to open it up to discussion.
Thank you, Sandy. That was excellent. I think an important point with this article to make note for the learners is that they did exclude radiosensitive tumors. So I think we've all seen patients with scary-looking lymphoma that melts away after a couple of days of radiation. So I think that's an important thing to keep in mind for everybody. I'd open up to our panelists if they have any more comments or thoughts. I think you're still muted, Dr. Courier.
Yeah. Hello, it's Pat Johnson chiming in. I appreciate all the talks. I think these are all great talks, and I want to congratulate Brad Courier and the whole group for putting these things together and reviewing all these papers. The Patchell paper, in particular, although it's a little dated, and it actually makes a huge point looking at non-radiosensitive tumors and which are a threat to the patient's well-being. And Sig, just to kind of oppose your concept about binary not being good, it was a binary study that basically looked at patients and said, does surgery need to be done on these patients, and paralysis or not is really the outcome. And they had to stop the paper partway through, or the study, and publish it. But it would actually really set things in motion that we do and it established really with the oncology world, because Roy Patchell was a neurologist. He's recently retired, which is unfortunate. I was going to invite him as a visiting professor, but just really a hard-thinking guy, and he thinks like a surgeon, which obviously we all like. But that was a huge contribution to really kind of set in motion, say some of these things have to get operated on, black or white. And I have to congratulate him for all that work that he did for his whole career.
I completely agree. And this is a classic paper. And again, to the Mayo group, Arjun, Brad, and the fellows, terrific papers, terrific topic. This paper is one I think would be very difficult to do again. It certainly was an important contribution, or is an important contribution to our literature, to our understanding of the role of surgery, especially in patients with metastatic disease with epidural spinal cord compression and neurologic involvement. But that to me is a subset of patients where there's rarely equipoise, right? Being willing to randomize requires equipoise. And it's pretty rare that I'm thinking about the subset of patients with a evolving neurologic deficit and epidural disease that I'm thinking about, especially in a non-radiosensitive tumor, that I'm thinking about not doing surgery. Largely maybe because the results of that surgery that's influenced our thinking about this. But to try and do a study like this again, I think would be awfully difficult, because it's rare that I've got equipoise when I'm thinking about how to treat these patients.
Well, I think we learned so much from this paper that you can't do this study again. I think it just set the course in an entirely different direction, and we know which patients are going to do badly. And, like the scoring systems, we can just simply look at those cases and we can say, this one needs an operation. with scoring systems or not, you can just look at it and tell, bad problem, this patient's going to go paralyzed. I think we've learned that as surgeons, which, you walk in the room and the oncologists are there with long faces, but we look at it and say, this needs to get fixed, and this is why. And we need to teach our colleagues. Because we learn from them also. It's a group decision, but a lot of these things that are surgical, we know it, and that's what we have to impart to them. So anyway, it's a great paper, and I don't think you can redo this one. I think you can try and figure out some other way, but it's already been established pretty solidly.
Well, that brings us to the end of our session. I'd like to thank everybody for their participation today. A lot of excellent discussion. Obviously, I'd like to thank the Seattle Science Foundation, Dr. Courier, and our two fellows, Dr. Hobbs and Dr. Bumanza, for helping out with this today as well. Thank you, everyone.
You guys did a great job.
Great job, Mayo. Thank you.
Thank you.
Thanks, guys. Great topic. Well
Stay
presented.
safe.
Thanks.
Thanks.
Have a good weekend.
Likewise.
Thanks.
Thank you, Alexis, Ashley. Thank you.
Thanks for watching. Hit the subscribe button for more medical content.